Public controversy within and without the psychiatric community, there is resurgent interest in ECT among researchers and clinicians, probably because of its efficacy when administered following a standard, albeit complex, protocol. Max Fink is professor of psychiatry in the School of Medicine, the State University of New York at Stony Brook.
There have been many changes in the treatment from the Chiletti, Bini, Meduna days of the 1930s, such that in the early 1950s, the introduction of succinylcholine led to the accompanying use of methotrexate or other barbiturates for anesthesia. In the early 1960s, the introduction of unilateral electrode placement. In the late 1960s, the importance of oxygenation, continued ventilation was discovered. And in the last 8 or 9 years, we've had a tremendous interest in the issue of whether brief pulse stimuli are better or safer than alternating current stimuli.
In the following videotape, we would like to present the indications for and the technical issues associated with electroconvulsive therapy.
The principal indications for ECT today are in patients with major depressive disorders, severe enough to be hospitalized. Even more compelling are depressed patients with suicidal ideation or suicidal intent.
I don't think I really did want to kill myself. I think it was,
But you thought about it.
I thought about it, and I thought
You told your
maybe
husband
because I
about it?
did it.
You tell your husband about it?
Well, yes, I did. I told him I did
Well, that's
take
the
a
reason you
few.
came in the hospital,
Yeah,
wasn't
I told him that I took, you know, well, I only took about.
It did.
About how much?
Well, I'd say I'd lost close to 65 pounds
65 pounds. In the
Yes.
previous 6 months, or previous month, or previous year?
in the past 3-4 months.
I'm still not eating.
You're not eating now. Why not?
I just can't get the food in.
What happens?
My throat closes.
Does it really close?
I don't know.
In fact, you have that tube in your nose. Isn't that for food?
Yeah.
And finally, depressed patients with delusions.
That woman that came after me, either a professional had told her what to say, or she was a professional. And my business place was
Why would that
violated.
bother you today? That was months ago, weeks ago.
That was a good job I had, and it was destroyed by interference.
How did the job get destroyed?
Because I won't go back there. I noticed they knew I was coming because I noticed how people jumped back from me.
The second indication for ECT are patients who have failed other drug therapies, particularly depressed patients who have been tried on other medications and who have failed either because the course was unsuccessful or because of medical complications. So that patients who have difficulty with handling a TCA or an MAOI are often referred for ECT.
The first treatment I had was a medication, and that wasn't effective. In fact, I seemed to go deeper into the depression, and I had some rather, what I would consider violent episodes.
The next group of patients for whom ECT is indicated are patients with mania or catatonia and who have not responded to other courses of therapy. Although some physicians will prefer to use ECT to lithium plus an antipsychotic and run the risks of a neurotoxic syndrome, and for some catatonic patients, their disturbance is so great that the usual 4 to 8 days that it takes for an antipsychotic drug to work is a bit long, and ECT given twice a day for a few days is very effective. There are some special groups for whom ECT is indicated, and that is pregnant women who are psychotic, and in whom, particularly in the first trimester, where there is some anxiety about giving them an antipsychotic or an antidepressant medication. And surely, if a patient is a bipolar manic, there is great anxiety about giving them lithium. Another indication for ECT are patients who have cardiac arrhythmias or hypertension, and for whom the TCAs may be a significant problem, particularly if the administration of a tricyclic is associated with hypotension, then ECT may be the treatment of choice. The same can be said for relapsing mania. There are patients who have manic episodes for whom lithium plus carbamazepine alone, lithium plus antipsychotic, the combination of all three have been tried, and the patient still is actively manic. A course of ECT can break up that sequence, and then the patient can be maintained either on lithium or carbamazepine or the combination successfully.
The principal risks of ECT include impairment of cognitive functions, fractures, and an incidence of death of 4.3 per 100,000 treatments, which is less than the age-corrected death rate for anesthesia alone.
But the most common risk, the usual thing that patients complain about and the family complain, is the patient has a loss of memory. And that occurs in every patient. Every patient has a loss of memory for the treatment itself.
It's a little scary going down the treatment wide awake, even though you know they're going to put you to sleep, and waking up in your room, and I never could figure out how they got me from the treatment room to my bedroom and to bed, because I have no recollection of that at all.
It is often said that the treatment has some bad effects on memory. Do you have any effects that you can tell me about in relation to memory?
Well, very, very minor things like I would forget, but otherwise, most of my memories, I would say, was all here, right? And if I did forget, it'll come back eventually.
Do you have any trouble in in caring for your children or taking care of your house or doing shopping now?
No, not at all.
Do you have trouble remembering what you have to buy and making up shopping lists?
No, it all came back.
Now, when we give a patient treatment over 3-4 weeks, they tend to have a fuzzy idea of what happened in the hospital. But the treatments themselves, the patients do not forget what happened in their early life. They don't forget what happened in their childhood. They don't forget the telephone, or don't forget the names of their children. They don't forget their work. And they have no difficulty in learning these things after the treatment is over, when they're better. Sometimes when the patients wake up after the treatment, they feel they have some headache, and they may have a headache for a couple of hours, a few hours, and usually that responds very well if we give them some aspirin.
I woke up, I had a slight headache on 1 or 2 treatments when I woke up, but that
Right.
was the...
That's right. You had some headache, and did you also have some muscle pains?
Yes.
Yes. Both of those occurred. Those were the
Right.
results of the treatment. Did they stay for a long time, or did they go away?
No, they left me.
Okay. For the headaches, did the doctors give you some pills of some kind?
Tylenol.
They gave you some
Tylenol,
analgesics.
yes.
Our treatment technique will now be demonstrated. The patient should neither eat nor drink anything after midnight preceding treatment. The morning of treatment, an IV line is started. If atropine is to be used, it is usually given at a dose of 1/150th of a grain 30 minutes prior to treatment, either intravenously or subcutaneously. Or it may be delivered through the IV line about 10 minutes prior to treatment. Electrodes for EEG and EKG monitoring are now applied. 3 for EKG, and 2 bifrontally and 1 ground electrode on the chest for EEG. Blood pressure is monitored repeatedly during and after the treatment. To monitor seizure duration, another blood pressure cuff is applied either to the arm opposite the IV line or to a leg about mid-calf. When a muscle stimulator is used to determine the effects of succinylcholine, apply 1 electrode to the ankle and the other to the popliteal fossa. Before applying the ECT electrodes, the skin must be cleansed thoroughly, first with saline and then with alcohol or a fat solvent. Electrode conducting jelly is used to ensure good contact. When bilateral placement is desired, flat metal electrodes are applied to both temples and held by a headband. When unilateral placement is selected, One electrode is positioned over the non-dominant temple, midway between the outer canthus of the eye and the meatus of the ear. The second handheld electrode is applied 1 inch from the sagittal plane near the vertex on the non-dominant side. Dominance is determined chiefly by asking the patient which hand he uses for writing and pointing, which eye for sighting through a telescope, and which foot for kicking a ball. If there is any ambiguity, the first treatment is given over the right or presumed non-dominant hemisphere. And during recovery, for the first treatment, the patient is carefully examined for signs of aphasia and anomia. If prominent, the second treatment is given over the other hemisphere, and the same tests administered post-treatment. Further treatments are given over the hemisphere producing the least effect on these functions. Patient electrodes are now connected to the ECT instrument. We shall not show specific connections on this tape. Please refer to the instruction manual or videotape supplied with your machine for details regarding appropriate connections and operating characteristics of your device. An impedance check is now performed. If the impedance is within standards set by the machine's manufacturer, the treatment can proceed. If not, the electrodes are reapplied until a satisfactory impedance is achieved. Anesthesia now proceeds with a 40 to 90 milligram, that's approximately 1 milligram per kilogram body weight, of methohexatol IV. Pentothal is usually not used because of a higher incidence of cardiac arrhythmias. When the patient is unresponsive to verbal stimulation, the cuff monitor is inflated, and succinylcholine, 40 to 90 milligrams, is rapidly administered through the same IV line. The extent of muscle relaxation is determined either by the decrease or absence of response to a muscle stimulator or obtunding or disappearance of a deep tendon reflex. Because there is direct stimulation of the masseter muscles with the ECT stimulus, even with complete succinylcholine paralysis, a bite block is essential. The jaw is held firmly closed with the bite block between the teeth. The stimulus is then delivered at settings adjusted to achieve the maximum effect using minimum current.
We now know that the results are equivalent whether you use brief pulse stimuli or AC stimuli. The treatment results with different stimuli and the treatment results with different currents are not in the efficacy, but seem to be in the safety features. In using AC currents, alternating currents, there is significantly greater evidence of EEG dysfunction, memory dysfunction, than brief pulse stimuli. And if one uses unilateral electrode placement on the non-dominant hemisphere, there is significantly less memory difficulty and less EEG effects than if one uses bilateral electrode placement. Ideally then, patients should be treated with unilateral electrode placement and brief pulse stimuli. But there's a small price for that. The price is that such treatments are more difficult to ensure adequate seizures.
If there is no evidence of improvement after 4 or 5 treatments with brief pulse stimuli and unilateral non-dominant placement, then a change to bilateral placement is made. In patients who are very ill, severely suicidal, or for those with medical risks, then treatment with bilateral electrode placement and brief pulse stimuli is recommended from the outset. The bite block is removed and ventilation with pure oxygen is begun. The duration of the seizure is determined by one or more of the following criteria: the motor activity in the isolated limb, the duration of the EEG seizure activity on an auditory monitor, the duration of seizure activity on the recorded EEG, or heart rate changes in the cardiac monitor.
All the evidence from a recent spate of studies done in Great Britain where seizures have been compared to non-seizure therapy shows that patients who get real grand mal seizures done regularly do significantly better in treatment response than those who do not have seizures. Now, when we talk about a seizure, there are 2 parts to a seizure. There is the part which occurs in the brain, the electrical and biochemical activity in the brain, and then there are the peripheral events, the hypertension, the muscular movements. We now know that the hypertension, the respiratory, and the muscular movements of the convulsion are not necessary for a treatment result. So we can block all of those. The essential philosophy that we have tried to achieve in convulsive therapy is the repeated administration of a seizure, and the seizure should be of sufficient length to be sure that there are electrical and biochemical changes occurring in the brain. And that length, we're never sure what is an adequate seizure, but with modern monitoring techniques, we have agreed in general that seizures of 25 seconds or longer in the peripheral manifestation, or in the EEG manifestation, or in the cardiovascular monitor, is the minimum for a satisfactory treatment. So the philosophy under which we operate is to induce seizures repeatedly in the central nervous system of 25 seconds in duration or longer.
After an adequate seizure has been observed, the monitoring blood pressure cuff is deflated. It may be several minutes, however, before the patient begins to breathe on his own. Ventilation with pure oxygen at 10 to 15 breaths per minute is continued until that time. When the patient breathes spontaneously, he is moved to the recovery area and observed continuously until fully conscious. The preceding technique is that of modified ECT. Some additional precautions may have to be taken in patients with severe cardiovascular disease, recent coronary occlusion, pregnancy, or any other medical condition which may increase anesthesia risk.
A major issue in convulsive therapy is how often to treat a patient and for how many treatments. The endpoint of a treatment course is ill-defined. First question is how often to treat. In the United States, 3 times a week has become customary. In Great Britain, twice a week. It is clear that therapeutic results are approximately equivalent in both Britain and the United States. It requires between 8 and 10 treatments in both countries. And the principal advantage of 3 times a week seems to be in the fact that one may get the treatment results slightly faster or sooner than one on twice a week schedule. On the other side, many years ago, Paul Blatchley introduced the idea of multiple treatments, 6 or up from 4 to 6 to 8 treatments in one sitting. And he claimed that such multiple monitored ECT was more effective and that he could get his patients better in 2 or 3 days. A number of observers, including Dick Abrams, Jim Strain, and others, have tried to replicate his results and have found it unsuccessful. At the present time, there is no compelling evidence that multiple ECT saves any time for patients. On the other hand, there is some good evidence in the reports from these laboratories that a small number of patients given 6 or 8 treatments in one sitting have a severe organic mental syndrome. And at this point, that method of treatment, multiple monitored ECT, is still to be considered a research question and not an accepted standard treatment. How does one determine the end point, whether one should stop at 6 or 5 or 8 or 10 treatments? The primary indication has got to be the clinical course of the patient. There is no substitute at this moment for what is euphemistically called clinical judgment. When the patient has shown a significant change in mood, in improvement in appetite, a change in the sleep pattern, a change in the thought processes such that the delusions are no longer expressed, well, then the physician should consider that this is the time to end the treatment. There was a time some years ago when physicians said when you thought the patient was better to give 2 additional treatments, and that was tested, and it really is not a good endpoint. When the patient is better, it's time to stop. We have a few indications from the laboratory that might be helpful. In the past few years, we've used the dexamethasone suppression test as an index, and the way we use it is simple. About 2/3 of the patients who come to ECT in our laboratory have a positive DST. That is, they have an elevated cortisol at 11 p.m., or they have an early escape. That is, they have an elevated cortisol after the administration of dexamethasone. In such patients, we ordinarily repeat the DST in the days after the patient has had 5, 6, or 7 treatments, and again, if they've gone further, 10 or 11 or 12 treatments. If the DST normalizes, we are reassured that the clinical judgment is supported. If the clinical judgment says the patient is better and the DST remains abnormal, we reassess the patient. We usually do it by talking to the family and re-examine the judgment that we've had, and we may continue to treat a patient, not treating his dexamethasone suppression test, but to treat the whole clinical case with the DST as an index. In general, it's been very rare for us not to get a normalization by the end of a course of treatment. What do we do with a patient who has a normal DST to begin with? Then the DST is of no help.
Well, I know in my instance, it was very effective in getting me out of the depression. And that as far as having apprehension about it, fear that there's pain or that it's some medieval type of treatment, that just isn't true. It's almost a non-entity.
There also are some other indications. Weight gain is a very good indication. If you're considering the endpoint and the patient's weight is the same or less than when the patient was admitted, think twice. Another one is the EEG. If you have had a baseline EEG before treatment and at the endpoint you find that the amount of slow waves produced is negligible, think twice, because usually accompanying a treatment response is a 10 to 15% increase in slow wave activity. And its presence is a good sign. Its absence, like the failure of the DST to normalize, should cause you to think twice about the endpoint. But the endpoint of treatment is always clinical. Your clinical judgment becomes the only criterion that is of any significance. Is there anything about the treatments or about the past few weeks that seems fuzzy to you? Or is your mind, as far as you're concerned, quite clear about the past few weeks?
Well, as of now, my mind is pretty clear.
How old are you?
I'm 65.
When were you born?
October 30th, 1919.
In the 1960s, a number of studies were done to answer the question whether giving antidepressant medication after a course of ECT is helpful in reducing the relapse rate. And the answer is yes. So that in most instances, for patients who have had a major depressive episode, the physician must consider maintenance therapy after the treatment course is over, even if the patient looks well and has responded quite nicely. Maintenance is done with a number of treatment possibilities. The usual maintenance is the administration of a tricyclic antidepressant. For some patients, the continued administration of a monoamine oxidase inhibitor has been used. There are some good reports on the continued administration of lithium, particularly in patients who've had a bipolar course. Question is often raised about maintenance ECT. Is it of any advantage to a patient after a course of ECT to get one treatment a week or one treatment every 2 weeks? And the answer to that is ambiguous. We do not have any good evidence in the literature that maintenance ECT is a successful prophylactic. The other question is, should one continue medication during the course of the actual ECT? And we have good evidence to answer that question for certain treatments. While there is no objection to continuing a TCA during the actual treatment, there also is no evidence that the combination of TCA plus ECT is a therapeutic advantage to the patient. And considering the possibility of cardiovascular events associated with TCAs, in general, physicians discontinue TCA administration during ECT. The question of MAOI and ECT is the same answer. There is no evidence that the two together have any benefit, and anesthesiologists are generally nervous about giving MAOI during a course of ECT because of the interference with the cardiovascular system. There is some good evidence that lithium plus ECT is not a good combination. Patients do develop an organic mental syndrome sooner and of greater severity for that combination, and so lithium should definitely be discontinued during the course of ECT. The continued use of an antipsychotic medication, particularly in psychotic patients, is a reasonable possibility. By that I mean the evidence from the literature and from clinical experience is that continuing an antipsychotic drug does quiet some patients down, and it is a safe procedure. And so that in our laboratory we have no hesitation in continuing either a drug like fluphenazine or perfenazine or chlorpromazine during the course of treatment. A principal question in convulsive therapy that's always asked is, how does it work? Now, in the course of the past 50 years, there have been literally hundreds of theories proposed. Many of them have been tested, and most of them have been found wanting. At this time, there are two principal theories about how ECT works. Both of them are biochemical in principle. The first is derived from our appreciation of the catecholamine theory of antidepressants. And it has to do with the fact that in depressed patients, there is some evidence that the monoamines are either too low or the rate at which they are being distributed in the brain has been altered or is impaired in some way. It also is a derivative part of that theory which has to do with receptors. And whether there are too many receptors or too few receptors for some of the brain amines, it's unclear. But within that framework, there is the usual expression that ECT works by altering either the number or the binding ability of receptors, or increases the rate at which catecholamines appear at the synapses, or the rate at which they are taken back into the cells. But that catecholamine theory is the principal one which many of the scientists working with ECS and ECT are working. It's a reasonable hypothesis, but as of this moment, there are as many objections to it as that there are supporting data. The other hypothesis we might call the neuroendocrine hypothesis. It starts from the premise that now that we have observed that there are neuroendocrine abnormalities in patients with major depressive disorders, particularly the disordered cortisol response, the disordered growth hormone response to insulin, there's a whole list of neuroendocrine abnormalities, the TSH response to TRH. All these abnormalities are seen prominent in depressed patients, and after a course of ECT, they all resolve to normal in patients who recover. We also now know that during the course of ECT, there is a liberation of ACTH, there is an increase in prolactin, there is a whole lot of substances come out of the pituitary and hypothalamus, and these substances seem to have behavioral effects. These substances are natural substances in the brain. We also know that these substances increase in the brain and in the spinal fluid and in the blood with ECT. And so a logical hypothesis of ECT action is that ECT stimulates the centroencephalic regions of the brain, that is, the brainstem areas, to liberate these substances or some other substances that we don't know, which have an effect on altering mood. And that's the theory upon which we are now operating, and that neuroendocrine theory turns out to be supported in part by the evidence of the change in the DST with successful improvement with ECT. There also is some evidence that some of these substances like vasopressin, when they're measured in the blood or in the spinal fluid, do change with the course of ECT, and may even change with a time course that may be of interest to the ECT. So the neuroendocrine hypothesis is another very active hypothesis. Either of the two theories can be presented to patients and to students as a reasonable explanation of the ECT process, as best as we understand it today.
The last but no less important issue in the administration of electroconvulsive therapy is that of informed consent. A course of ECT should never begin without an appropriately executed consent form. Common to the variety of forms in use are the following points. 1. A statement indicating why ECT treatments are to be given. 2. A listing of the medical risks associated with ECT. 3. A brief stepwise description of the procedure. 4. A clause that allows the patient to discontinue therapy at any time during the treatment. The consent form must be signed by the patient. Consent requirements in cases where the patient is incompetent to sign may vary from state to state.
Convulsive therapy is a treatment that has been in existence for more than 50 years. Of all the other treatments in clinical psychiatry today, it has been around the longest, excepting perhaps for psychoanalysis. It's a difficult treatment to give. It's an expensive treatment to give. It's a frightening treatment to you, to the patients, to the families. It's a treatment that we would like to replace by something better. At the present time, we have nothing better for certain patients than convulsive therapy, and therefore we're doing our best to continue to use it safely. However, the most essential element is for each physician to use the treatment as best as our modern standards can show, or we have learned to use it under optimal conditions, and at the same time to encourage the research that is necessary in order to find a replacement.
Hi, I'm Dr. Richard Abrams. I'd like to show you how to use your new Thymatron ECT instrument. In the first place, inside the carton you receive, in addition to the Thymatron, you'll find a number of other items. There will be the stainless steel treatment electrodes, 2 of them of the flat disc type for bilateral ECT, 1 of them cupped to fit into the unilateral ECT handle. There'll be 2 head straps for holding the electrodes with perforations. There will be a unilateral ECT handle for taking the cupped electrode. There'll be a tube of electrode jelly. You'll receive 3 leads for recording the EEG and displaying it through the audible ECT seizure monitor. You'll have a few sets of disposable paper electrodes for recording the EEG. There will be 2 cables to plug into the front, which we'll discuss in more detail detail later, the EEG cable for recording the EEG signal, and the ECT cable for administering the stimulus and also for testing the impedance. In addition, there will be a cassette tape of the audible EEG of the Thymatron during the treatment of a patient so that you can hear exactly when the seizure begins, what it sounds like, and how it ends. You'll get 2 copies of the Thymatron instruction manual written by myself and Dr. Swartz. And finally, a copy of the Thymatron service manual, which is for the use of your biomedical engineering department. Before going into some of the details of what you do and the procedures that you go through when you treat a patient, I want to show you briefly the front and back panels of the Thymatron to familiarize you with some of the aspects. On the front panel, first we see the impedance dial, or a meter, and the button for testing the impedance. The jack-marked ECT has 2 pins, accepts 2 pins, and is for taking the cable which is used to administer the ECT stimulus. The jack-marked EEG accepts a 4-pin plug and is for recording the EEG signal. In the center of the instrument is the percent energy dial. This is what you use to set the treatment stimulus. It has 5% steps of total energy, and each one has a click-stop detente. The power switch that turns the device on and off is here in green, and the red button underneath the hinged protective plastic cover is the treatment button. The back panel of the Thymatron is also uncluttered and uncomplicated. Of course, there's the power cord, which has a hospital-grade plug at the end, which should be plugged into a hospital-grade receptacle. There's the fuse. There's the speaker for transmitting the signal from the audible EEG and also the warning signal and the stimulus signal. There's a volume control knob for controlling the output of the audible EEG, but not either the signal of the stimulus or the warning signal. And there is the jack for plugging in the optional EEG chart drive recorder, should you have one. Now, before starting to treat a patient, or even before putting the Thymatron into service at your hospital, I recommend that you have the machine checked out completely by your biomedical engineering department using the Thymatron service manual, following the procedures outlined there. And I also recommend that this be done on a yearly basis, which is routine in most hospitals. In addition, you should, of course, completely read through the Thymatron instruction manual, as it contains a very detailed step-by-step description of exactly how to treat a patient. Finally, you should familiarize yourself with the device by unplugging all cables from the front, turning it on, and pressing the various buttons and adjusting the treatment dial so that you will understand exactly how simple this is to operate. Without the cables in place, there is no risk, there is no way to get a shock, there is no risk to a patient or yourself, and you cannot damage the machine. Press the impedance button and you will see the impedance meter register. Of course, without the electrodes in place, it registers all the way to the top. But now, or in the treatment of an actual patient, you can press this as often as you like, at any time, even while the patient is awake. Turn the percent energy dial, set it to 50, and then flip up the treatment button cover, press the treatment button, and observe the sequence of events. I'm going to do that a few times so you can see. Power on, press the treatment button, You can do that as often as you like. When the treatment dial is set at 50% energy, the Thymatron will deliver a 2-second stimulus. And you can check that as something that I initially do each day before treatment. The first thing that happens when you press the treatment button is that you hear a 1-second warning signal, and the light does not go on. If you continue to hold your finger on the button, as you would in a real treatment, the button would then light up, and at the same time, you will hear the signal of the treatment stimulus being passed. If you continue to hold the button down, as you should if you want to treat your patient, the signal will continue for the 2 seconds that is equivalent to 50% energy, and then it will go off. You will hear the signal stop, and the treatment button light will go off. After the treatment button light goes off, you will hear the sound of the audible EEG of the Thymatron, and if you were treating a real patient, you would hear the typical seizure activity, which I will try and demonstrate for you later. So here's the sequence again. Power on, set dial, press the button, warning tone, stimulus signal, audible EEG signal, which is adjustable, softer or louder by the volume knob on the back. The volume knob on the back does not alter the warning signal or the treatment tone. Now, what about the procedures for treating a patient? In the first place, although you might be inclined to turn the power on, I usually wait until I've followed all the procedures of getting the patient prepared, putting on the electrodes and head straps, etc., and wait until I'm about ready to test the impedance before I press the power switch. First, you must decide whether you're going to give unilateral or bilateral ECT. For bilateral ECT, select the 2 disc electrodes and place them in the head strap like this. You'll have to estimate at first the interelectrode distance, but you'll get the hang of it very quickly. You cleanse the patient's scalp using an alcohol swab, making sure to remove all the oils and grease from his skin, both on the temples and on the forehead, because you'll also be putting on the EEG electrodes. And then, with the patient lying on the table, you simply slip this under his head and estimate the distance. You then adjust it. You apply electrode jelly to the 2 electrodes, and then simply put them around the patient's head like so, fastening it in the front. That would be for bilateral ECT. For unilateral ECT, you only use 1 electrode with the strap, which we place over the non-dominant hemisphere, which is the right hemisphere. And then, for the other upper electrode, you take the cupped stainless steel electrode, insert it into the unilateral assembly, and apply it to the scalp just medial to the vertex. When it actually comes time to treat the patient, the power cord, which has the 2 pins, is plugged in, and it has a positive lock. And there will be 2 banana plugs. If you're giving bilateral ECT, you put 1 into each disc electrode for the treatment. And if you're giving unilateral ECT, you plug 1 into the handle of the unilateral ECT assembly and the other into the single disc electrode, which will be attached to the head strap. If you are recording the audible EEG, as I suggest you should in every case, you take the 4-pinned plug and plug it into the jack marked EEG. You will see at the end of the jack has 3 receptacles. 1 is green and the other 2 will be a different color. And these are to take the EEG electrode leads. The green one is the ground in every case, and you take the green pin and plug it into the green receptacle, and then either of the other two into either of the other two receptacles. It doesn't matter. As long as you have the green in the green, you'll be all set. The green is the ground and simply gets attached to the patient's shoulder, and the other two electrodes are placed bifrontally over the forehead after they've been carefully cleaned with an alcohol swab. The electrodes we recommend are the disposable paper ones, which simply peel off, attach like that, and accept the clip of the electrode lead. And we generally place them, as I said, over the forehead. At this point, when the patient is prepared, has the electrodes applied, you want to test the impedance. You can do it while he's awake. You simply turn on the power switch and press the impedance button. Now, we don't have a patient here, so I'm going to use a dummy resistor and simply plug these two banana plugs in and demonstrate what it looks like. Press the impedance, and as you see, the impedance meter registers somewhere in the middle of the dial. This is the desirable area. Anywhere in this middle section is fine. It's quite safe. The only two caveats are, if the impedance measures only in the first bar, there may be a short circuit between the electrodes, and you should check for an electrode jelly bridge. If the impedance is all the way up on the upper 1, 2, or 3 bars, that means the skin to electrode contact is not good. The impedance is too high, and you should clean the scalp again and reposition the electrodes. After the impedance testing is satisfactory, I'm going to unplug these now for safety. You then have to set the percent energy dial to the treatment stimulus that you desire. We recommend simply setting this as close to the patient's age as possible. So if you have a 65-year-old patient, you simply put it on 65 and he's ready to be treated. This is possibly an overestimate of the actual dosage of electricity, perhaps a 10 to 15% excess, but it ensures better than a 98% reliability in getting seizures the first time. If you find that you get a full seizure, you can then turn back the treatment dial later on. But for the first treatment, we always set it to the patient's age. After the patient has been anesthetized according to the procedure, the recommended one that we like is in the manual, but you may have one of your own. After the patient is asleep and has been fully relaxed by a muscle relaxant drug, it is then time to treat him. You simply flip up the treatment button, press it, hold it down while the light comes on and goes off, and then release it. And now the patient is having his treatment, and if he were hooked up, you would hear the activity of the seizure. If you release the button during the warning signal, before the actual stimulus occurs, nothing happens. The light will never go on, the stimulus will never pass. This is in case you accidentally press the button or at the last split second decide that you really don't want to treat the patient. Once the treatment stimulus starts, releasing the button will abort it instantly. This means that he will receive only the stimulation that has already occurred, but no more. For example, let's say we were to set this all the way up to 100% energy, which, if you will consult the Thymatron manual, on the back you will see that 100% energy is equal to 4 seconds of stimulus duration. Well, this is what the 4-second stimulus would sound like. 1, 2, 3, 4. If, however, you decided in the middle that you didn't want to continue the treatment for one reason or another, releasing the button would simply abort it. This is another safety feature of the Thymatron. Although a audible EEG cassette is included with each Thymatron, I'd like to demonstrate for you how nicely the audible EEG corresponds to the EEG which would be recorded on paper by the optional chart drive. I'm going to turn on the chart drive and then press the treatment button, and you'll observe the correspondence between the EEG signal during the seizure. This would correspond to the tonic phase, which would then gradually be replaced by a slowing down into the clonic phase, with each burst of EEG activity being represented clearly as an audible and as a visual signal. And finally, when the seizure stopped, there would be a constant sound which is entirely analogous to the constant flat baseline of the visual EEG. As you've seen, the Thymatron is really quite simple and uncomplicated to use. Dr. Swartz and I have treated many patients with it and find it highly satisfactory. In one hospital in New York City, earlier this year, they gave over 1,100 consecutive treatments with a 98% reliability rate in obtaining a seizure on the first treatment. I think that's quite remarkable. Should you have any problem with your Thymatron or want to discuss any aspect of it or using it in treatment, simply call Somatic's toll-free number. Either Dr. Swartz or myself will be glad to discuss the problem with you. Thanks.
Peter Evans was born in Ottawa in 1955. He was a cub. He sang in the junior choir at church. He skied, skated, swam, and he studied ballet.
Being gay has never been a problem for me, so I would save that whole sort of aspect of the problem. Whereas for someone whose family didn't know, having to face both of those things at the same time would be a real, like a double crisis in their life, which I can understand would be, very difficult. I mean, a lot of AIDS patients have been disowned by their families anyway when they found out. It was a lot easier for me, I think, because my parents have known I'm gay for a long time, and I didn't have to face that, of letting people know that I was gay, as well as the fact that I had AIDS. So I had their support from the beginning, and that made all the difference.
In 1977, Peter moved to England to study theatre design at the Old Vic. Then he worked as a stage designer. Late in 1982, he became severely ill. The diagnosis? AIDS, the acquired immunodeficiency syndrome.
It's really a question of one thing after another, which is one of the most frustrating aspects. You sort of just get over one thing and something else crops up. I had the pneumocystis, which was accompanied initially by the sort of really severe bouts of diarrhea, and night sweats, which were extraordinarily severe. I was having to change the bedding and stuff 5-6 times a night. Skin infections, herpes zoster, which I have now, and then accompanied by all kinds of sort of non-specific things like migraine headaches, constant nausea, and off and on periods of very severe diarrhea, which has lasted quite a long time. Parasitic form of TB, which I had after the pneumonia. Just sort of endless lists of things like that. You just get one thing under control, and then you pick up something else.
Each of us is protected from disease by an immune system. It discriminates between things that are self and things that are non-self.
Invasion by a foreign organism or germ is invasion by something that's non-self, and therefore it will be recognized as such, reacted against, and destroyed. The development of an abnormal cell, which could potentially become a cancer, is also recognized as non-self, reacted against and destroyed. When someone gets AIDS, there is a breakdown of the immune system. The reason underlying this, or the reason for this, is really totally unknown at this point. The immune function gradually diminishes. In other words, the ability to protect and destroy has been lost. As far as we can tell, there is no way that the defense system can be reconstituted by any of the known means. And at the present time, as far as we know, the outcome for someone who has been diagnosed as having AIDS is most likely 100% death.
The definition of what we call AIDS is a very small component of the disease. This is probably very much like other viral infections, where some people who come in contact with the infection do not manifest any symptoms. Others have very minimal symptoms. Some have more severe, and some would go on to develop what we call AIDS, which is the most severe manifestation. Well, we know by definition that AIDS is the occurrence of a disease that should not happen in a person who has normal immune function. And this includes what we call opportunistic infections, infections by agents that a normal person would not become infected with, such as pneumocystis carinii pneumonia. And in addition, it includes a very rare tumor which does not affect young people, called Kaposi's sarcoma.
The syndrome now called AIDS wasn't clearly defined until 1981 in the United States. Diseases that had almost never affected otherwise healthy young people were suddenly killing them. Though very little was known about this frightening phenomenon, that hasn't prevented a great deal of nonsense being said and written about it. But it seems this kind of reaction isn't unique to AIDS. A century ago, one of the least understood and most dreaded sicknesses was cholera.
This was a disease that had been known in South Asia for a long time, but was a novel experience in Europe and in North America. It was a disease that could strike very quickly. People could be healthy in the morning and dead by mid-afternoon. The victims often turned a grotesque blue color. There were no effective therapies. Both the doctors, the regular doctors, and the quacks had a variety of therapies, none of which were effective. So it was a situation primed for panic and hysteria. It's also important to notice about cholera that it struck a higher proportion of poor people and otherwise disadvantaged people. Some people interpreted it as religious leaders, interpreted it as God's wrath to punish the sins of the people who lived in cities. Cities were perceived as overcrowded, unhealthy places filled with immorality and sexual excess. Cholera is interesting because it diminished and then disappeared in the 19th century before any effective medical response was possible.
The greatest fear that people used to have of cholera or TB is the same one they have now of AIDS. Will I catch it? Will someone I care about catch it?
Well, to date, the only people in whom AIDS has occurred are people who we believe have acquired it through sexual transmission or through contact with blood or blood products. The evidence against transmission by casual contact is indirect, but is fairly strong. Healthcare workers at the beginning of the occurrence of this disease were exposed to AIDS patients quite intensely without any precautions being taken, and to date there have been no cases in this group of people. There are a number of groups in whom AIDS occurs in which we understand the transmission, and these include male homosexuals, intravenous drug users, and hemophiliacs. In addition, there are other groups in whom AIDS occurs where we do not know what the means of transmission is. And in this group is included Haitians and a number of other individuals with no distinguishing characteristics. AIDS has been found to occur in women, and of U.S. cases, about 6% of them are in women. These women usually have had contact with males who are in AIDS-affected groups, such as bisexual males or males who are intravenous drug users. Other women who have contracted this are intravenous drug users themselves, or fall into the group in which we don't know how AIDS is transmitted, such as the Haitians. Many people are worried about catching AIDS through routine activities of day-to-day life. However, there is no evidence that you can catch this disease by casual skin contact, handling either food or belongings, or sharing public facilities.
Because AIDS affects groups of people subject to prejudice in this country, fear of the syndrome provides a ready excuse for blaming the victim.
Well, there seems to be a fair amount of almost prejudice seems to have arisen, and I think it's because of the media presentation of AIDS, which has been fairly drastic. Oh, the people call up and say, for example, a friend of mine has a gay son and he's living at home. Is it safe to go over and visit? Or I'm having a dinner party and there are going to be several gay men invited. Should we take special precautions with the dishes? We have people calling the AIDS office saying that they have, for example, a Haitian housekeeper, and should they continue employing her? They have Haitian women looking after their children, and should this be continued? Should they let them go? And then, of course, there's been the issues of healthcare workers who have refused to look after AIDS patients in Toronto, in the downtown hospitals. If somebody comes around to the office who's worried in terms of this sort of thing, what we do is we take them to the clipping file and show them the latest research on AIDS, which almost, well, universally states that AIDS is an exceedingly low communicability, and for all intents and purposes, one has to have absolutely intimate contact, which means that on a casual social level is, well, for all intents and purposes, impossible to catch.
Current data suggests that AIDS can be passed from one person to another via blood or blood products. Particularly vulnerable, then, are people who need constant transfusions. For example, hemophiliacs whose own blood lacks the vital ability to clot in order to stop bleeding.
My son David does need blood. He needs a great deal of it. In the last year, he's consumed the blood of 80 donations in 25 separate infusions. As he gets older and into adult life, he'll be using the blood of from 500 to 1,000 donors per year. I think you can see very easily that the risk to a hemophiliac of picking up any infection from blood, including AIDS, is a lot higher than it is for the general population. And what do I do in the case of David? I have to make a decision about whether he should be treated or not. I don't hesitate at all. The risks to his health and his life are far, far greater from not treating in those situations than they are because of AIDS or hepatitis or anything else.
About 400,000 patients receive blood or some form of blood product in Canada each year, and about 4 million in the United States. In the 3 to 4 years that AIDS has been reported, that means some 12 to 16 million people. Very few cases of AIDS have developed in this group without some other risk factor associated with them. Other blood products have been known to be safe from the point of view of transmitting infection for many years. Albumin can be pasteurized, which inactivates virus. Antibody concentrates, because they concentrate a neutralizing agent for viruses, are also entirely safe when made by present methods. There's no suggestion at the moment that AIDS has introduced any new risk as far as the use of these products is concerned.
There is presently no definitive test for AIDS in the laboratory. As a result of that, the nursing department and the blood transfusion service is the first line of defense. But they always have been. From the very beginning, we've always been aware of diseases that are contaminants, if you will, or bloodborne, or would be in some way harmful to a recipient of that particular unit of blood. Considering that, we developed a donor criteria manual many years ago that has very, very strict criteria in it. The questionnaire that was developed in conjunction with this is something that is used regularly with every single donor that walks through the doors who is potentially going to give us a unit of blood. It's very brief, very concise. It has been recently revised as a result of the AIDS crisis. It asks questions that we expect honest answers to, that will allow an individual to seek further information from the nursing department, and we ensure that the individual has in fact read this by challenging him at different points during the donation process. We have the responsibility of maintaining the integrity of a national blood bank. We include our donor in that step of protection.
One of the many steps we take in order to protect our donor is to use sterilized, single-use, disposable needles, tubings, and bags, which makes it impossible to contract any disease during the process of donating blood.
It doesn't make me angry. I'd much rather it hadn't happened. But I don't think I added to my chances of getting it myself. And it's just one of those things, it's accidental. I don't think anyone, no one planned to give it to me, or, I think if you sort of blame yourself that way or blame other people or put the blame on the world at large, it's just a destructive way of looking at it for yourself. I mean, things like that happen, and it is something you've got to accept.
Confronting ignorance and panic is the first step toward solving the problem of AIDS. As with any illness, the other steps involve treatment, the search for a cure, and where possible, prevention.
What you could do if you didn't want to catch AIDS is stop having sex entirely, which is fairly unrealistic. I think the next step down would be a monogamous relationship, and then again, if we take another step down, what we can do is just, in terms of plain mathematics, reduce the number of partners, which, I mean, obviously is going to cut down your risk of catching anything from the common cold on to any other sexually transmitted disease, on to AIDS.
It's also advisable to know who your partners are and to wear a condom.
At present, there's intensive research underway trying to identify what the agent that causes AIDS. Once we've done this, we'll be able to devise specific treatment for the disease or even develop immunization. At present, however, there still are many things that we can do. People who have Kaposi sarcoma or opportunistic infections can be treated for these conditions and helped to stay as well as possible while research is underway to try to determine more specific treatment for their underlying condition.
The overwhelming feeling for the last 10, 11 months is just that my life's been put on hold. The sort of inability to work and being separated from the person I love and from my life, and it is sort of just existing and waiting for something to happen. Up until now, I haven't been able to sort of be out of touch with my doctors and things for more than a week or so because something always crops up, and it is a sort of waiting game, and as I said, sort of fighting each thing as it comes along, which in my case have been fairly continuous.
If a confirmation of having AIDS is forthcoming, the people then really have no idea where to turn because of the stigma. Again, they frequently do not tell parents, loved ones, friends, work associations. They tell no one at a time when they perhaps need the most support they will need in terms of dealing with it, coping with what is going to happen to their lives. This is the last thing in the world anyone wants to think they have, not only because of the physical danger, but because of the social stigma associated with it. In one situation particularly, a brother, a young man who was very, very close to his sister, had told her he had AIDS, and she came in from a holiday and as was her norm, she rushed up to him and kissed him. This was very, very important to him because he was aware of the fact that many, many people feel that AIDS can be contracted by touching, which is ridiculous. It's very, very difficult to change attitudes. Information, accurate information, is actually one of the best ways about the entire AIDS syndrome, what it means, what the real dangers are, what the complications are, what the likelihood of the various physical manifestations are. The types of support the people need depend to a large extent on what is happening to their bodies. Those that are associated directly with persons with AIDS can, of course, talk to their doctors. Information is also available from the Public Health Department, and it's available from the AIDS Committee of Toronto.
Well, there's quite a likelihood that I will die from it. If you deny the possibility or sort of block it out completely, that's, again, is just destructive to you. You know, not admitting the possibility is pretty senseless. I'm not planning on it, but you know, you have to look at both sides and sort of prepare for it, and I think I've prepared as well as I can. I mean, I certainly don't want to die, but if it happens, it happens.
Peter Evans was the 35th person in Canada to die from AIDS.
Most people, once, you know, given the proper information and the facts and just the knowledge to work with, understand it and lose their hysteria about the whole thing. I just wanted to do whatever I could to help people understand and to sort of try and get the true facts across and make it easier for people to sort of identify with, you know, being able to identify with somebody or being able to sort of look at someone who has it makes it easier for them to accept.